So as we continue this dialogue, the last thing on the menu is the clinician panel. It's an expert panel, but not really a panel. We really were hoping to focus in on whatever clinicians are left in the room, and if you're willing to answer questions, both from the floor and on the internet. I know people who couldn't be here had sent in some questions, and just hoping that there's a spirit of willingness and participation among clinicians who are still around. I know a lot of people had to leave because of travel restrictions. Dr. Eichler, I'm looking at you. How do you feel about it?
Okay. Well, I can start with the questions that have been sent in, and then if anybody has burning questions on their mind, just raise your hand, and we'll take it from there. So, going out with a bang here, right? Everybody, use your reserves and energies. What non-drug treatments have your AMN patients used, and how did they work? Okay. So I guess that would be maybe between Brian and me. In terms of adult ALD, non-drug treatments would span everything from...
I mean, I think that... There we go. I think therapy is a big basis for this. A lot of the AMN patients are on a continuous therapy program, whether that's kind of in spurts where they're going for certain goals and they're there for 2 weeks or 8 weeks, 6 weeks, 8 weeks, or if they're on more of a maintenance program ongoing. I think both have benefits, and you have to fit life in as well, which is sometimes challenging with some of those maintenance programs. Outside of that, I don't know.
Yeah, you heard a little bit earlier about sort of bowel and bladder treatments. Some of them are medication related, but there are certainly exercises that can be, and dietary changes that are undertaken in that realm. Are balance problems common in AMN patients, and what approach helps? So I think it's fair to say that balance problems are common, and they are related to the dorsal tract of the spinal cord. These are the long tracts that bring signals from the peripheral nerve up through the spinal cord to the brain, and provide the brain information about where our joints are in space. This sort of proprioceptive information is difficult to arrive up at into the brain, and is one of the reasons why it's so important to have vision to compensate as far as you can for these balance problems, and why a lot of patients experience worse balance problems in the evenings where they cannot compensate with vision. What approaches help? I think physical therapy.
It's a challenge. So there's studies out there that show that proprioceptive work with therapy, where you're working on balance things, do improve your proprioception. But I think at times, and I had this discussion over the break, a lot of the therapists are a little hesitant when it comes to these neurodegenerative diseases, and they're not sure exactly how far to push the patients. And they're doing pretty well where they're standing independently and they're not falling, but they're not pushing them further in terms of putting them on an off-balance surface and that sort of thing. And so I think potentially pushing that a little bit further may be needed in some of our patients. And then the other question is, I don't think we have good studies in neurodegenerative diseases as to whether or not these therapies actually are helpful. But we know from other diseases that it is. It's just a matter of whether we can actually extrapolate that.
And there are ways of not physical gene PT therapies that you can find in the community. And I think it was mentioned, hippotherapy is an excellent therapy to engage the sensory system, the proprioceptive system, in a way that is not risky. If you are in the right environment and the right horse, please do not go cowboy. That is not a good idea. But and then there is a lot of places where you can enhance other sensory modalities. So Florian was talking about vision, and a lot of the training is literally to try to enhance your other sensory. So instead of like just going blind across the hallway, like turning your head before you're gonna turn your body, that will change your sense of space, and it will prevent you from having to adjust too quickly, where you may not have the response for that. We also, from the stroke world, not from the ALD world, know that under the water, there is a lot of more range of motion of everything you move, because you get gravity out and your spasticity gives you a break. So if you have a chance to get to a pool that is also safe, so water safety first, you could experience movement in a very different range that you do when you're on standing with gravity pulling you and the spasticity making your range of motion more limited. And that also is more sensory experience for that system. At the end of the day, you want to keep the system and the other parts of the system with the sensory, like touch of it, engaged. So it kind of always practicing something new. I think novelty, whatever you do that has a little bit of novelty, that's what Brian was saying. The physical therapists sometimes are hesitant to push you into like these more ruggy surfaces. But in reality, that's the only way that we know to keep this system trying to be trained is novelty. You have to get out of the flat, systematic, always the same. And I think the other thing is devices, no? So for safety, so you can increase your world experience. So think about anything you carry around, not only as the cue for the world around you to not go and slump into you, but also as a way to expand your access. Okay, you can go much farther, sometimes even having someone carry the wheelchair for you, but then you don't have the limitation of saying, oh, I'm not going shopping, or I'm not going to that event in my kids' school because I know I won't have the endurance. So you walk whatever you want, and then you hop on the wheelchair if you need it to take the break and keep going. So I always think as devices as expansion of your environment, not as a limitation of mobility.
Just one more comment on specifically on the dorsal column of the spinal cord that is responsible in AMN for the balance difficulties. We know that this long tract is also one vulnerable to certain deficiencies. Particularly vitamin B12 comes to mind. So I always say that this is something that can be easily checked and easily replaced, because if you have B12 deficiency, that will also hurt your particularly your dorsal column and making sure you don't have a myelopathy related to other factors or things that could aggravate AMN. So I'm going to try and combine the next question, which is recently, have you used any new therapies? And is the success rate for a perfectly matched sibling donor the same as that for gene therapy, or are better than the others right now? Okay, I think what I'm hearing here is how would you compare the perfectly matched sibling donor compared to gene therapy? And I think that's a big discussion right now. It's nice to have these options where you are able to have different possibilities. Right now, we see a perfectly matched sibling donor for conventional bone marrow transplant as probably preferable, maybe to gene therapy, where there are still risks around long-term safety that we don't fully understand. So in that situation, we would probably choose a matched sibling donor if available, given that the risks of graft versus host or engraftment problems are quite low. New treatments. I don't know. Patty or Brian, do you want to talk a little bit about what's in your field or your horizon?
I think we all heard today, even from Dr. Van Haren and their industry panel, that there is an attempt. So we know that it's very difficult to stop the disease once we're talking about the cerebral form in the childhood presentation, once the disease is there. But I think we're trying to really understand, this is work that I think Eric is leading, what is really the thing that is happening before you see the MRI lesion with all those things and characteristics. And if we understand who is going to do what, like a boy at high risk, a boy at low risk, then is a window of interventions that opens up. So there is a trial with the agonist that Dr. Minarex has been pushing forward in the European Union and in the US, where this molecule will try to improve the vascular system and decrease the inflammation both at the same time, with the aim of capturing very early lesions and try to hold them before they go into getting contrast and being candidates for transplant, all while they're getting prepared for a transplant, to kind of see if we can slow it down, or if we get super lucky, if we can stop it without having to receive chemotherapy and the transplantation of a bone marrow or a gene therapy. There's a million things we don't know, and that's why it's been done as a study. The first thing is to try to gather the data to understand, is there an effect, is it safe, and what is the real dose that we need. So that's one of the things that we've been trying to engage and work. And I want to emphasize one thing. Always remember, bone marrow transplantation is not a possibility for more than 80% of boys affected in the world. You guys have no idea what luxurious situation we have, the ones that we are here in the room. And because I speak Spanish and I come from Latin America, I am a point person for a lot of the developing world. And my conversations are very difficult because even when they are diagnosed early, the delay to a bone marrow transplantation is 6 to 8 months. So imagine your boy diagnosed with a lesion, you know what you need to do, you even have a donor, and you still can't get to the bone marrow transplantation in time to really salvage neurological function. So if you always ask me, I'm part of the gene therapy trial, full disclosure, supported. I'm part of any efforts to really stop the disease because it's doing what it's doing. But we really need something that the rest of the world could access. And you know the cost and the safety of a bone marrow transplantation is something that many hospitals across the world cannot afford, healthcare systems across the world cannot help doing. So I always say, yes, we're looking. We're still looking very hard. And I think newborn screening has opened a whole window of questions of how do we keep them, as Keith was saying, healthy? How do we keep them healthy? How do we get them to serve the 2 peaks and hopefully the last peak in adulthood, which we don't know when it happens, but also that.
So maybe on that note, Eric,
It's 2 on. All right. So this is a question that sort of dovetails on what you were saying, and I'm going to try to channel Keith and his brilliance here. So it's the question: should ALD children, cerebral or pre-symptomatic, receive more vitamin D supplements than was included? So this is essentially his trial, and this is essentially what we're trying to figure out in the pre-symptomatic imaging world, as Patty had mentioned. What does that pre-symptomatic window look like, and can we buy ourselves some time? And so to go on, these sort of questions are related, looking at antioxidants, which vitamin D is one, N-acetylcysteine, I think this is resveratrol. Have any of these, can we combine these for ALD and AMN treatment? I think there's hypotheses around the biological plausibility of this working, and I think part of Keith's brilliance is picking something that's available all over the world, something that is relatively standard of care across the globe, and something that actually has data. So would be interested and really excited to see how that works out. But keeping in mind the disparity, I think, is one thing that crept up during ALD Connect this year, but something that I think we definitely need to focus on.
Yeah, so I'm just going to chime in and say combination therapy is going to become a topic, I think, in the coming years, as we are seeing more drugs being developed, and I think that's a good thing. I think as a community, the challenge will be to emphasize rational trial design, and that I think should be part of our general awareness and education. What do I mean with that? I think as we are facing different treatments and different medications, we have to understand what the targets and what the mechanisms of these medications are. It may not make sense to combine two different medications that are equally efficacious in lowering very long-chain fatty acids. Okay, if one medication cannot lower very long-chain fatty acids, the other one can, it may make sense to combine them, right? And so I say this because I think as a community and as patients, you have to develop a certain awareness of that thinking and that logic, so that you can make informed decisions for yourself and your families as we step into this future. I think the future is bright, but it is going to get complicated. And so we have to know why we're starting new drugs, medications, and supplements, and in what sequence, and with what rationale and safety. And so I would hate for us to be in some future where we're using all sorts of cocktails and the waters are muddied. But that's just sort of my take on it.
And I wanted to add, like, we all want to hope that everything that works or is showing promise is going to work. And we also have to acknowledge the experience and the data that we have from some of these therapies. And sometimes the medication, like antioxidants, for example, can have an effect, but as you heard before, it's a matter of getting into the right place. So if you want to get that dose in the brain, your stomach won't tolerate it. So you have to develop other kinds of strategies. So it's not as simple. I'm saying this because Florian has been part of another trial in a different disease where the patients went out to find the treatment on these herbal centers. And it is not necessarily true that because you're putting something in your mouth is reaching the target or is tackling the mechanism. And that doesn't rule it out that it could have effect. Or in the other hand, there might be things that is not worth exposing yourself because they won't have an effect. And I think it will be really good for a community like this to develop a couple of questions that you will go anytime that they approach you for a trial that you should ask. It's like, for how long am I doing this? What happens if it doesn't work? Do I qualify for another trial at the same time? Or how much longer after I finish this one? Because then you can tell, okay, am I buying into something that it will prevent me from the next thing available? So I think in the education of how to being approached as a trial subject, we can help develop as a community those kind of questions that make you, to help you with the judgment. And at the end of the day, you will have the information that you need to make the decision.
Maybe I can bring a list into this. I'd be very curious if in the coming years we could think about other ways of improving adrenal health beyond supplementing what's missing. And I wonder whether you have any thoughts on that. And granted, this may be a difficult topic, but I don't know if you want to speculate.
At this time, we don't. But I just heard this morning about things that I may not be able to share, so I will not until it's open. But there are possibilities that we could recover some adrenal function. So we'll see.
I think these are going to be some of the discussions we're going to have in the coming years, right? We've for decades done things like supplementing the hormones that are not being made, and now we're starting to think about how can we mimic the natural flow or physiologic cycle, but maybe we'll get to the point where we say there might be some resilience to that adrenal cortex, and can we still reverse things similarly as we might think that the early cerebral lesion is still modifiable, and why aren't we doing that for the adrenal gland and the adrenal cortex? So I think they're very exciting things that are going to come our way. But I want to just look around if there are questions that people have.
I am online. I'm part of a Women with ALD kind of group chat through Facebook, and a topic has come up recently that resonated with me, and I just wanted to ask. Um, Someone brought up the fact that they seem to have auditory processing issues, in that I hear you saying words, but if there's a lot of other distractions or sounds or conversation going on in the room, that many women reported that they have to continuously, and it's annoying to your family and friends, you're constantly saying, I'm sorry, what? What? I can't hear you. Even though, yes, I hear this, people hear this sound, but that they don't process it. They're not sure they're processing it appropriately. And I will say, oftentimes, I don't know if anyone else in the room is part of this Facebook chain, but often we struggle with the idea that not everything that vexes us is ALD, and we're not quite sure because ALD as a whole, but female ALD is not, let's say, crystal clear in the parameters and how it affects people. So I was just wondering if any of you have experience with women in particular having, and I don't know, maybe it's a men's issue as well, and I just am dark to it, but if that's an issue that you see.
Yeah, good question. I don't think we see this consistently enough to say this is an issue we see in women. As you just pointed out, I think the first rule in clinical care is to not attribute it to ALD and make sure you're doing your utmost to work it up and understand whether this is an inner ear problem, is this sort of a peripheral nerve problem, and if necessary, do a brain MRI, but don't think that this is necessarily ALD. I think with women over the years, there's always been a similar question around joint pain and joint inflammation, and again, that also being a relatively common disorder with age, you want to first treat it as a non-ALD related. I think there's in the coming years we'll learn more about how much inflammation is due to ALD and how much is not. But I think for now we would be safe to say this is not ALD related.
I think the other thing to remember, and we have had people bring this up recently in clinic, is that auditory processing is one of the things that can be highly affected by sleep and mood. And so a lot of women go undiagnosed with things like anxiety, depression, and ADHD, and don't become diagnosed until well into their 30s. And auditory processing, that the way it's been described by a lot of the women, can be that. And so if you're putting all this added pressure of a new diagnosis and not sleeping, I think that can also be a huge part of it.
You always, an evaluation, if it's a recurrent issue, is warrant. And auditory processing is not available so easily as a test. So you probably want to change some of the other things. If the hearing is still intact, you want to try like improving your sleep, trying to decrease the anxiety. And if it continues, then push for accessing that kind of testing.
I think the other thing to look at is, when is it happening? Is it happening when you're only in a crowded space where there are lots of things going on, which is what I've heard more, or is it happening in one-on-one conversation? Because if it's one-on-one conversation, then that's an actual auditory processing problem, right? But if it's when you're in a crowd, I think that leans much more towards it being your brain being overwhelmed and kind of shutting off.
I would say, because there was a robust discussion about this in this group, that majority of people fall into the category of it's in a crowded space, there's or there's a TV on, or there's other stimulus coming in, and people are finding that they repeatedly have to ask for clarification. So I think everyone would be excited to hear it's not ALD, because that seems like that's not totally fixable yet. I think people are always excited to hear, no, look elsewhere. might be something that can be fixed easier.
Justin.
Okay, I hope I don't start a fight with this question. But it nonetheless is something that always spins around in my brain. I don't know that we've ever had a conversation in this community, ever once, about the concept of invasive maneuvers regarding therapies and treatments, right? I'd like to like envision myself in some like island off to like East Coast that's like all dark, and there's like this chamber, and there's like this weird doctor who comes in, and he's like a brain surgeon, and he like digs into my brain, and like he does something. And that's the thing, I don't know what that person would do. I don't know what
What are you trying to tell us, Justin?
I'm just curious if anyone's ever thought of, is invasive going in, to my cortical spinal tract and doing something. I don't know what you would do. I don't have a single idea of what that would be. But nonetheless, it's funny to think about that just in terms of like our bodies and what can be done, and what do you guys think about that?
Patty, how far is the stroke world away from brain transplant?
Thank you, Florian, for the very interesting question. So, no, I think what he's going after is there are a lot of more common diseases that damage the spinal cord, that damage the brainstem, that damage the same areas that get affected by ALD. And you do have crazy people all over the world offering in tiny islands or big lands of countries all these kind of invasive therapies where the most important thing is nobody cares about safety. And I'm going to say that because when you touch your brain, you know how careful we are not touching your brain, is because it does not regenerate that quickly, or it doesn't at all regenerate. And there has been a lot of experience with cells or anti-inflammatories. In MS, it has been crazy stuff done to the vessels of patients with no benefit other than the patient feeling I am doing something really big for myself. And I think that's the challenge for all of us, not just you, the affected person, is like, when is it seeking to do something the right answer for the problem? Sometimes the answer is not doing, and the answer is taking care of what is there, not looking for what is not there. I'm saying this more in a philosophical way, but it's probably more helpful than start dissecting every single thing that you could think you could do invasively that would not have a benefit for you as a man or as a woman. I think that is the most important question, is like, is the right thing here to do or not do something? And where can I put the focus of this energy that I have? I do want to get better. So how do I do that with what I have? And then whenever you go experimental, and we are all experimentalists here, you really want your, I gotta say, this guardian, my middle and my oldest brother said that I have not a guardian angel, a troop of them, because I go through the world like travel the whole thing like alone, and nothing happens, and even when things happen, things showed up and fix it. Okay, so my brothers believe on this. So when you think about disease, healthcare, and invasive procedures, you do have guardian angels. It's called the FDA. It's called the IRB. It's called the European. And I'm not we tend to think about these entities as like evils that put bureaucracy and just delay things. I would have to say the conversations I have had with the FDA, with you in the room, without you in the room, are always like, are we doing the right thing? Are we protecting the life that is there? The capacities, the abilities that you have, or are we just going to hurt them? And the only answer to that is, what's the information, the data that you have about where you're at and where you want to go?
What I basically just hear you saying is the danger far outweigh any, and I understand.
Like the dangers, right, of tinkering around in someone's brain is obviously very severe. I totally understand that.
I think So I do a lot. I've done with rehab. We've done spinal cord injury, and there was a large study, the NACIS study, that looked at high dose steroids after a spinal cord injury, and there was an increased risk of death. There was an increased risk of pneumonia, but there was also an increased chance of walking. And so, because of those risks of death and pneumonia, the FDA and the medical world said, no, we shouldn't be doing this. This is a higher risk than what it is. Years later, they started talking to the patients, and this is where I think it's important for you guys to take control of this and decide what the risks, what the benefits that are worth it. Because a lot of the patients said that they would be willing to take that risk for an increased risk of pneumonia and serious medical complications for an increased chance of walking, despite those risks. And so it's that risk-benefit kind of balance. And it's hard, we do our best to kind of do that as well, but I think it really does come down to the patient population and what risks they're willing to take in terms of invasiveness. And that, I think invasive has a different meaning to everybody.
Yeah.
Thing that he's talking about has more than 5,000 patients treated. So what I'm saying is the data that you're basing your decision has to be there. And we're not judging the decision, we're saying like gather the data.
Yeah, and so you're sort of touching on doing the right thing, and I think your question's really well founded. So I have an ethics background, so that part of my head is screaming right now because I think you're asking the right question. Are we doing the right thing? Is it data driven? And are we keeping you safe? Are you keeping your brain safe? And then I also want to say this not in a bad way, but as a patient, you're a vulnerable population because there are people out there trying to sell you things. There are people out there trying to sell you cures. And when you end up there, I'm not there. I don't know what that's like, but I know you do. And our best guidance is, we're going to try to be the guardian angels. Maybe I'll borrow some of Patty's because I have none. But, the idea is the data there and is doing something for the sake of doing it, especially when there's a system that's semi-predatory, if not fully predatory, on people like you. It causes us to really sit back and try to keep you close. Because you hear all this stuff, right? The stem cell therapy. It was touched upon yesterday, and Troy mentioned it. People go and get stem cells, stuck into their spine. And we had a case at Cornell a little over a year ago where someone grew out a chordoma. They grew out a mass because they went to another country, they got stem cells plugged in, and then the person stopped walking. So and you can't hold those people accountable. They're in another country, right? So it's really the ethicist in me is really worried about that.
But just to put this in context, so we, in the ALD field, we are taking bone marrow cells and we're correcting them with the lentiviral vector in a dish and giving chemotherapy and putting those cells back into the body. And I think what you will see in coming years probably is some attempts also with direct injection into the ventricles of these kinds of cells, knowing that we understand the safety of administering them systemically. So I think to come closer to what you might be wanting to see in terms of progress, every step has to be sort of a well-controlled, safe step. And it might seem incremental, but together I think we're going to be making amazing progress. But it has to be in the right context and with the right risk-benefit.
The question here is, what major symptoms do you treat in your AMN patients?
Yeah, so I can start and then you can chime in. So, the major symptoms we see in AMN are essentially gait changes, balance problems, and bowel and bladder issues. And I think we're very excited that we have a first trial for AMN that is placebo-controlled, double-blinded. So we don't know yet whether it works. We hope by next year we will be able to report out with the effect of that. But I think short of that, we're use many symptomatic treatments. And Eric?
I think I want to just speak to the importance of the bowel bladder. And is Camille still here? Camille, your work is, I think, was excellent this year. And it really is just it really highlights what we're doing outside of neurology, and some of us neurologists we're trying to address it, but pulling in the world of urology I think is really important, and not just understanding AMN as a neurologic disease, but a true multisystemic disease in the same way that we adopted and treat the endocrine symptoms as well. So really, I think highlighting that was really important. And yeah, go from
Yeah, and then I mean, we talked about the balance, spasticity, kind of our control over our musculoskeletal system and safety, and then function, and really improving what we're doing and expanding our ability to do things, whether that's through assistive devices, braces, other medications. Adaptive sports, that's a good question. So somebody brought up, I think earlier, they'd said, I used to be a skier, I used to be that, and now I can't do those things. And I kind of cringed at that. I think we all can do those things. There's ways to do them. They may look different, but there's lots and lots of different adaptations to all of these things. And skiing is one of the bigger ones, and running and biking. And really, if you had a passion, you had something that you loved doing, pursue it, look into it. There's ways of doing it. And our adapted sport teams and groups are really capable and wonderful to work with.
Yes.
Are there other things that are on your mind that were not touched upon at this conference? Are there other questions, other fields? Yes?
So I'm trying to figure out what to call myself. Oh, hello, Mike. Interesting to call myself not a carrier now, but to say that, okay, I have AMN. I can't say ALD because that to me is such a severe form of what I'm not experiencing, but is everybody coming now to a name for us women?
I think we'd still come to woman with ALD because of the gene, that is affected. It doesn't mean that this is now brain disease, cerebral, and we don't think when we say the word adrenoleukodystrophy that means brain disease. That's why we use the term cerebral ALD if we talk about brain disease. But I think we would say woman with ALD. We wouldn't say woman with AMN, and I think that just because it too much pushes the comparison with adrenal myeloneuropathy, and women different from men with AMN don't have adrenal insufficiency. So I think that's something we have to be careful about. So women with ALD, not AMN.
Just get a microphone. Nope. I disagree with you.
It wouldn't be the first time, Katie, nor the last time.
Although I will say,
yeah. Within the next hour.
I do think that the women maybe should come up with, I don't know. Part of me likes the idea of you just saying ALD because people get very confused about this AMN, adrenal, cerebral ALD, and thinking it's three different things. That being said, I have also heard people say that as a woman, they want their own diagnosis because when you Google ALD, people are going to be like, yeah, you're crazy, you don't have that. Whereas if we got a new name, then maybe, you could be Warrior ALD.
Florian, I have agreed with you for years. I've told all my doctors.
Now I'm getting into trouble.
I have ALD. It avoids so much confusion. I'm laying there waiting for anesthesia. Look up ALD. And in Europe, and on the ALD Connect website, the video on women talks about that. Women have ALD. We have the gene.
Yeah, I think we have to separate out the term ALD as meaning you have the gene from what is the manifestation thereof. And I'm just worried about the term adrenal myeloneuropathy because it really means a manifestation. It means you have adrenal insufficiency.
But that's where you're wrong. So you automatically lose the argument because there are men that don't have adrenal insufficiency that have adrenomyeloneuropathy. So if that's the argument, then they no longer have AMN either.
But the vast majority develop adrenal insufficiency over a lifetime, and women don't.
In your thing that do have adrenal insufficiencies.
I would also note that all of your notes, medical notes for the last 10 years say female with AMN.
And I also said that in all of those women that I examined, there were other reasons for them to develop adrenal insufficiency. Okay.
Sorry. We'll talk about myeloneuropathy in ALD and kind of specifying that to pull it out from that adrenal aspect. It's very complicated. I don't want to really step in it.
Yeah, no.
I'm going to add a practical thing. Don't make the disease even more rare, okay? So you got a wing with ALD on the top. That's why it's ALD Connect. If you start branching, which sometimes is very tempting because then it makes you feel, oh, I identify exactly with this. I would say educate yourself, and as they were saying, your ALD manifesting somehow. Which way? And you could be completely asymptomatic, or you can have adrenal insufficiency. You can have a neuropathy. You can have a myelopathy. You can have cerebral inflammation. You could have cerebral arrested disease. There's so many, like if we go on and on and on, and we want an acronymous for, because I know Americans, you really love this thing of everything has to have an acronymous. When you come to this country and you don't speak this language, it's the biggest nightmare in the world. It's like, what? I just want to take this subway. How do you get there? So try to, you won already a humongous, look at what is happening to this community. So keep it as a community, and everybody has the right to be unique in the way you experience the disease. So labels also don't say who you are. They never do. Not even your own name says who you are. So
I do want to provide clarity, so if it's not clear, please let me know.
Yeah, no, I think like what I hear is not necessarily that they need their own names of this mutation, but in fact that they're just really looking for like everything you look up. When we look up adrenal leukodystrophy, AMN, whatever it may be, everything says that it's an X chromosome mutation that affects men and boys. Nothing states for the women, and I think what they're really just trying to state is that although ALD Connect and all of the sponsors may know this, to the mainstream media and everything else, they don't.
We have ways to go in terms of disease awareness, and I take the point that there's a lot of education that needs to reach out beyond this room, and we're working on it. And I think all the people who are here or have been here been contributing to that. So we need a lot more work on women. I will say that in December there will be the first conference in Europe on women with ALD, sponsored by the European Leukodystrophy Association. So I'm very excited about that. Both people from Europe and the US will be attending.
Thank you. In this country and in English-speaking countries, it seems we use that word carriers for women. I wondered if in non-English-speaking countries there's an exact translation or they...
Yeah, portadora, portador.
Bomber. Thank you.
And way worse than our situation, they are being told by their physicians that they do not have any disease manifestation whatsoever, even to this day. There is a very, very small handful of neurologists with ALD experience that also see the whole spectrum. So they're even wrongly informed about it wasn't.
This isn't unique necessarily to hear it. Hemophilia is an X-linked disease, and women with the carrier status there get joint bleeds. At Melanie's talked about different X-linked diseases that the women carriers have some of the disease. So I think that there's a failure kind of more broadly than just.
I think the word carrier is a great place to start changing things, because you can pinpoint that that is wrong and that we should use a different term, and it opens up the discussion to clarify things.
Listen to the webcast on the ALD Connect website. Europeans, and it's emphasized in that webcast, women have the gene. They speak about women with ALD.
Really, you guys should be coming up with this answer. It has nothing to do with what's Maureen wants.
And when I'm educating people, I usually say, but women often have a less severe form of the disease.
This was a great discussion. All of us are around afterwards if there are questions, so I'm volunteering.
So thanks again, everyone, for your willingness to come, your willingness to participate. I'm so impressed and always so honored that people are willing to take time out of their busy lives and come together and discuss this really important topic and to build this community even further. As always, if you want to get involved in ALD Connect, reach out to us. If you're interested in suggesting something to make this newer, better, bigger, improved next year, our ears are open. To the extent that we made any missteps or things didn't go as you planned, our apologies, but we really hope that you look at the collective of what we've created here, and thank you for helping make this a reality.
And a big shout out to Kathleen. I think we all have to thank her for everything she's done, not just today or yesterday, but in the past few months. And I know that Kelly will be following in her footsteps and together continue this legacy. So thanks so much, Kathleen.